Okay, can you all see the slides? Hello?
Yes, we can see.
Okay, great. So let's start. So today we're going to talk about antipsychotics and schizophrenia. And as the usual, if you have any questions, just email me about the lecture. So by the end of today's lecture, you need to be able to know explain what's schizophrenia and its associated symptoms. And then you need to be able to discuss or describe the various theories of schizophrenia, classify the antipsychotic drugs, and correlate the mechanism of action of antipsychotic drugs with the dopamine and the serotonin theory mainly. As well as discuss the adverse side effects of the various antipsychotic drugs and their action. So let's start with something just to jog your memory of something more interesting. So Leo Hollister was a famous psychopharmacologist. He said that he witnessed 3 miracles in his lifetime. The first one was penicillin, because he saw patients who had like life-threatening or otherwise fatal illnesses saved by penicillin, and then corticosteroid, which was patients who were in wheelchair with rheumatoid arthritis were able to move after treatment. And the third was chloropromazine. So chloropromazine is the first antipsychotic drug that we have. And so that's something to remember. And it was the same as with all drugs that are used for psychiatry. It was discovered by pure serendipity, just by chance. So schizophrenia is a disorder of thought. It's marked by disturbance in thinking, cognition, emotional reaction, and social behavior. So schizophrenia usually results in chronic illness and personality change. So basically, it's a disturbance in attention, memory, and complex thinking. And people with schizophrenia, they have lost touch with their environment. So one of the symptoms, as you know, it's delusions and hallucinations. And usually people with schizophrenia, they're very good drawers. So you can see here, for example, a patient with schizophrenia describing his illness by drawing showing the paranoia, like as if there's 2 heads or 2 brains or 2 minds in his head. The other one is the hallucination, with the auditory. So the hearing as if people are talking to them or asking them, commanding them to do things and pushing them like to write. So they lost that sense of touch with the real world. So they no longer know what's reality and what's not. Also, there's a cognitive disturbances with the thought disorder. So which is they suffer from something to do with their cognition, so attention, their memory, and complex thinking. So they're not able to do that, and they can't do this without help from other people. So, and it also they suffer from symptoms like depressive symptoms. So here, this drawing by one of schizophrenic patients describing the depressive mood that he goes through, which is also one of the symptoms. They also have stereotyped movement, meaning like sometimes they just keep playing with their hairs. They can't sit, or they like cross and uncross their legs. So they just become agitated, and sometimes they're aggressive. They become socially withdrawn from society because they can no longer maintain long-term relationship with either family, friends, or partners. And sometimes they have flattened affect, i.e. their face doesn't have any emotions. They don't respond to any emotions. You can't see them like smiling or angry or sad. So it's just like a flattened, they call it a flattened effect. No, you can't tell how they feel just by looking at their face. So basically, it's because schizophrenia is known as the mad, bad, and sad. So it's a very nasty illness to have, basically. So, and it's not a split personality. So you need to be able to differentiate between split personality and multiple personalities. However, schizophrenia can progress individuals. So they can have episodes and they can just go through periods of normality and then get back into psychosis. And some people, they just have something chronic and progressive, so they slowly get worse and worse over time. They don't recover, especially if it happens earlier. And it affects 1% of the population. So for example, in the US, that's about 2.4 million Americans, and it's very disabling and costly. So annual cost total about 62.7 billion, because it accounts for most of patients in long-term psychiatric care and many of society's outcast homeless people, basically. It often has a very relative young onset. So people with schizophrenia, it doesn't start in their late teens, early 20s. For example, for males. For females, it starts in late 20s. And sometimes they think that estrogen might be a neuroprotective because of the late onset. However, 25 to 50% of those diagnosed with schizophrenia usually attempt suicide. 10% of them succeed. So the symptoms of schizophrenia is divided into two. We have the positive symptoms that I've just described, which is the delusions, hallucination, thought disorder, irrational conclusions, and also the negative symptoms, which is withdrawal from social contact, flattened emotions, and cognitive deficits, i.e. attention and memory. So are you all okay until here? Do you have any questions? Okay. So let's start with the etiology and causes of schizophrenia. Although it's still, we don't know much about it, but it's divided into three categories. The first one is genetic factors. So it has some hereditary tendency. So it happens, there's a percentage of 10% if it happens in the first degree relatives. If it's the second degree relatives, then it's 2 to 3%. Then if both parents have schizophrenia, then that goes up by 35%. And in monozygotic twins, if one of the twins has schizophrenia, there's 50 chance that the other one will also become schizophrenic. There are lots of genes that have been identified, but we still don't have a single gene that is related directly to schizophrenia. The second one are environmental factors. So if maternal virus infection, so if the mother has any virus infection, that sometimes they think is a leading cause, or could be a cause in schizophrenia later in life, but we still don't know about that. There's also neurodevelopmental problems in the cerebral cortex and early prenatal development, because usually schizophrenia appears in, as I said, in the late teens, early 20s, and that's the time when people, your brain has just been developed, especially your prefrontal cortex. So if there's any issues with the development of the brain, then that's the time when the onset of schizophrenia happens. And that's why it's linked with prenatal development. There's also developmental disorders. So it's prenatal insults. Maybe they think that maybe there's alter in the nature course of the brain development. Because, for example, they've seen that low birth weight or premature birth, or even exposure to hypoxia, low oxygen during birth is linked to schizophrenia. So many people who are schizophrenic are related to being born around either low birth or maturity, or experiencing low oxygen during birth or delivery. Also, babies who are born in winter and spring has been associated with becoming schizophrenic later in life. But these are still all theories. We don't have any conclusive evidence to suggest there's a direct link. So But what we know that mostly it may not be just one causative agents, but it could be like like a combination of also. It could be genetic, prenatal insult, and trauma in late adolescence that actually lead to its schizophrenia, development of schizophrenia later on. So another symptoms of people's schizophrenia that I need to mention is a pre-pulse inhibition. So pre-pulse inhibition is a preceding stimulus. So when you hear a sound like that, so and then you become alarmed immediately because it's not something that you were aware of or you were about to hear. But once you hear a bang sound or alarm sound, then you start to analyze the environment around you. And if you hear it again, so here is your first response after hearing an unexpected alarm. You get a startle response, you become alarmed, and because it's not something expecting. And then if it happens again, because you know that it actually happened, this time when you hear the alarm, it's your response is greatly reduced. However, in people with schizophrenia, they don't have that. They keep hearing the same alarm. If they hear the same alarm over and over again, they will always have the first initial response. And this is thought to be responsible. The thing that's linked to it is dopamine receptor agonist. So if there's an impairment in dopamine receptor agonist or 5-HT receptor agonist, it's linked to the startle response. So as I said, schizophrenic, they are not able to analyze their environment and make a decision to see what's happening. So they suggest that the pre-pulse is linked to these two receptors, these neurotransmitters, and hence any antipsychotics that are developed, they need to be able to restore the pre-pulse inhibition in schizophrenic patients. So let's look at the evolution of antipsychotics. When they first started, as I said, chloropromazine was the miracle, as is known in the medical field. But before that, in the early 30s, 40s, it was just the electroconvulsive therapy, which is just giving them basically electricity to their head, or Reserpine, the drug that we talked about on Thursday. But it wasn't up until we discovered chloropromazine that we started to understand what's actually happened. And chloropromazine was actually first discovered as an anesthetic, and shows to have a sedative effect. So when higher doses were given to antipsychotics to actually relieve their positive symptoms. And since then, we've been developing drugs that actually have similar effect to chloropromazine, which is haloperidol was the first one, and then flunofenazine, and so on. And those are known as the first generation antipsychotics. They, however, have like really debilitating side effects because they target the dopamine receptors in the brain. So they block the dopamine receptors in the brain, and that can have side effects, like patients can have Parkinsonian side effects as a result of that. So then not until the late 70s, 80s, when we discovered the atypical antipsychotics, and these, they still function in the same way as the first generation antipsychotics, but they also target the serotonin 5-HT receptors. But their side effects is mainly that they cause a huge weight gain, like severe weight gain in patients, which could lead to cardiovascular disease and other complications. Aripiprazole is the one that is a partial agonist, and it has less side effects, severe side effects, compared to the atypical side effects, but it's still counted as an atypical antipsychotics. So what basically you need to know from here is that we still don't have a really good a drug that actually, as we call it, like a breakthrough in antipsychotics, because we still don't know what's happening. And schizophrenia, people don't know, is it just one disorder, or is it just a group of disorders? So since the 90s until now, we haven't really gone any further. So the antipsychotic medication is basically depends on the dopamine hypothesis, which I'm going to talk about. And the only thing that I need to mention is that they all work on the D2 block for reducing the positive symptoms. And that's the main effects. So the thing is that the D2 receptors, they have a potency because they block mainly the dopamine D2 receptors. So if the drug has high potency and high affinity, we usually administer it as very low dose, like for example, cyperidol. And the more the low affinity the drug has, then we increase the dose. Like chloropromazine, for example, is given at high doses. But the thing is, with high doses also always comes more side effects. So now I'll talk about the theories of schizophrenia. As I said, we still don't know what's happening, but these theories, as with any other psychiatric illness, is like we discover drugs by pure serendipity, and then from that we learn how this drug works, and then we try to understand the pathology of the disease. And hence, because of the early antipsychotics, the typical antipsychotics, we came up with the dopamine theory. And then the atypical antipsychotics, we came up with the serotonin theory. Later, now we have the glutamate and GABA dysfunction theory. But we still don't have drugs that actually target these. So I'll talk about first the dopamine and schizophrenia. So as I said, the classic schizophrenia is a dopamine hypothesis. It formulated in the 50s and 60s, around the same times when we discovered how chloropromazine works and its effect on schizophrenic patients. So it's based on the findings that all antipsychotics, they work by blocking D2 receptors. But also, they've noticed that patients, for addicts who take amphetamine, also have like psychotic or schizophrenia symptoms. So amphetamine induces psychosis if it's taken long term, and amphetamine is actually a dopamine agonist, so it increases dopamine. So from that theory, from what we know about chloropromazine in the 50s, 60s, and the typical antipsychotics plus the amphetamine, we came up with the dopamine theory. That schizophrenia is due to hyperactivity of dopamine system. So the dopamine hypothesis, as I said, it's dopamine hyperactivity in the limbic system and hypoactive in the prefrontal cortex. So hyperactivity is related to the positive symptoms, so the hallucinations, delusion, extreme reactions, aggression. Hypoactivity, on the other hand, is related to the depression-like mood, social dysfunction that we associated with the negative symptoms, and is due to low concentrations of dopamine. But what you need to understand is that you need to bear in mind that the blockade of dopamine causing the antipsychotic effects and dopamine agonist causing the psychotic symptom does not necessarily mean that these symptoms are due to overactive dopamine. There could be another system that is functionally altered. So by blocking dopamine, antipsychotic drugs do not necessarily reduce an excess in dopamine in the schizophrenic brain. They could simply restore the relative balance between dopamine and other systems. So it's the same as I said with amphetamine, maybe because amphetamine, and why is that? Because amphetamine is also a dopamine mimicking drug. So it could be due to a creation. So maybe amphetamine works by creating an imbalance between dopamine and another system, which is usually regulated by dopamine. But this is still, it's a good, but the dopamine theory, it's still good, but I just need you to understand that this is not just the full story. There could be something else going on. However, because of the effectiveness of the antipsychotics, the blocking of the dopamine D2 receptors by these drugs is very effective on the positive symptoms. And it's really important because it has been notoriously difficult to demonstrate the hyperactivity of dopamine in post-mortem schizophrenic patients' brain. So this theory actually and antipsychotics helped with that. So do you guys until here understand, or is it too much? Okay, I've got a question. May not increase, they decrease others. Yes, the thing is, it's complicated. We don't know, but for sure what we know until now is that the hyperactivity in the limbic system is related to in the mesolimbic system is related to at least the positive symptoms, and the hypoactivity in the prefrontal is related to low dopamine. So maybe there's effects of other systems like the 5-HT, as I said, the NMD, the glutamate receptors, and the glutamate and GABA as well. So it's a complex system. It's not an easy question to answer. So now this is the dopamine. So I'll go and then I'll talk about the serotonin. So the serotonin actually came from LSD, which is a drug. It's actually a drug of abuse. So people that take it, and it shows to cause schizophrenia-like symptoms in human. And LSD is 5-HT2A agonist. And it also data shows that low concentration of the serotonin metabolite, which is called 5-hydroxy acetic acid, in cerebral fluid are associated with the suicidal behavior in patients. So in patients with schizophrenia, and it's related to the negative symptoms. So from that, it came the theory of the implication of serotonin came to light, and hence also the atypical antipsychotics, because they work on the antagonist of the 5-HT2A receptors, later proved the theory of the involvement of serotonin. However, there's also interaction between 5-HT and glutamate, and this is where the theory came into, where the glutamate theory also came, so which I'll talk about now. So these are all the receptors that are implicated or known to be involved in the, they think that also implicates schizophrenia. So the glutamate system, as we know, it's the major excitatory signals in the mammalian brain. So they're important for cognition, memory, and learning. And the receptors for glutamate, the NMDA receptors, AMPA, and also kinase and other metabotropic glutamate receptors. Also, the cortical efferent and cortical connections, they're all glutamatergic. And post-mortem studies and genetic studies shows implicate both glutamate and GABA, because you know, if the level of glutamate are affected, GABA will also be affected. So the theory of glutamate didn't come until the 1995, that the hypofunctionality, i.e. the NMDA receptor is not working in full power. The hypofunctionality of the NMDA receptor is implicated in schizophrenia. And NMDA hypofunction basically in the thalamocortical circuits produces a reduction in inhibitory function, which is usually mediated by GABAergic neurotransmission. So usually there's a glutamate overstimulation in the cortical regions related to psychosis in schizophrenia. And the evidence came from that is from phencyclidine and ketamine. They show to cause, those are both, phencyclidine, for example, is a drug that's given, used to be given as anesthetic. And then the doctors noticed that once patients come out of the surgery and they recover, they suffer from psychotic symptoms. So, which was weird. And from that came the fact that, well, phencyclidine shows not only the positive symptoms, but also the negative symptoms as well. So it was a very a great advancement in understanding of schizophrenia. And basically, the work that I used to do before I came here was basically giving phencyclidine PCP to induce some of the symptoms that we see in human schizophrenia. So we give them antipsychotics for, say, a week, IP injections, and then we see a resemble of the negative symptoms of schizophrenia. So social isolation. So the rats, they like to be in the group, but the phencyclidine ones, they tend to be stay from the other peers in the box, and they don't eat well. So you do see some of the resemblance from just even in animals when you give them phencyclidine. And have the model, we try to give drugs to see how they work to improve the symptoms in preclinical. So for example, when we administer glycine, this enhances the NMDA receptor and improve the symptoms, in particular, the negative symptoms. And clinical studies shows that when you give glycine and you add other antipsychotics, actually it helps improve the symptoms, the negative symptoms particularly. And as I said, there are other evidence to show that there's abnormalities in schizophrenia, like changes in the density of AMPA kinase and other NMDA receptors. Now, when you block dopamine receptors, we reduce, well, that's what we think, that we reduce dopamine in the mesolimbic. So we try to bring a balance. So it's reduction in the mesolimbic system, whereas it's an increase in the mesocortical. That's what we think they work. Because you block receptor, they're not agonists, they're antagonists. So you're bringing that balance back to normal, basically. And this will also, so now we know about the glutamate. Then, as I said, if glutamate is affected, then GABA is definitely affected. And we know that GABA is a major inhibitory neurotransmitter, which causes the membrane hyperpolarization, i.e. reducing neuronal activity, and is produced by the carboxylation of glutamate. It's a reaction catalyzed by the enzyme GAD. And there are alterations in both glutamate and GABA in the brain. So the theory of the GABA dysfunction in schizophrenia, it's consistent with the neurodevelopmental hypothesis that I talked about earlier. And also post-mortem studies that decrease in tissue content of GABA, the prefrontal, in the human prefrontal, and also patient schizophrenia, they showed a reduced level of GAD67, which is the enzyme responsible for GABA in the prefrontal cortex. So this all suggests that the prefrontal cortex is very important in